right. Good morning, everyone. Welcome to our September Geriatric Medicine, formerly Senior Health Town Hall. We're so happy everyone could join us today. My name is Susan Edgman Levitan, and I'm the director of the Stokel Center for Primary Care Innovation at Mass General, and I'm going to be your moderator. Before we get started, I just want to share a few housekeeping rules. First of all, everyone on the call except for the person speaking is muted, and we do that to eliminate any unexpected background noise. You can view the speaker on your full screen, or you can go to the gallery view to see all the other people on the town hall. If you go up to the upper right-hand corner of your Zoom screen, and you can click on which view you'd like. If your picture becomes jumpy or out of sync, click stop video in the lower left corner, and that will help speed up your internet connection. For questions, and we really hope you have a lot of questions, please use the chat feature in the bottom ribbon across the bottom of your screen. But I just want to remind everybody that anything you write in the chat or anything you show in the chat can be seen by everyone. And so we really want to remind you not to ask any personal medical questions. We don't really want to see any rashes or anything because it can be seen by everyone. But if you do have a medical question, please reach out to your doctor directly. We look forward to all your questions. We'll do our best to answer them. And if we don't have enough time, we'll try to get more information out to everyone after the call. We have really terrific speakers today. Our first speaker is Dr. Erica Chenoy. She is the Associate Chief of the Infection Control Unit at Mass General and an Associate Professor at Harvard Medical School. And we've had the very good fortune of having her really play a very important leadership role in all of the work that we've done to respond to the COVID pandemic. And then we'll hear from Dr. Sharon Levine, who is the section head of the Geriatric Medicine Unit at Mass General. So with that, I want to welcome Dr. Chenoy, and let's get started.
Okay, great. Can you hear me? Maybe a thumbs up, Sharon? Good. Excellent. Well, thanks for having me. I'm going to be giving an update, about 20 minutes of material, and hopefully I've anticipated some of the questions that have already been sent in. I'll give a brief overview of where we are in the pandemic. I'll talk about variants and vaccine efficacy, get lots of questions about how good are the vaccines we have against primarily the Delta variant. A little bit about how vaccines are approved and how these recommendations come to me, because if you're listening to the news, I can imagine it's pretty confusing with dates about when boosters come and how to make sense of it all. I'll go through the current vaccine recommendations, talking about the initial series, what we call the primary vaccination series, and really two use cases for additional doses. The first being a third dose for individuals who are moderately or severely immunocompromised, and then the concept of booster doses for other eligible populations, and then go through the FAQs that I've heard from this group already. Okay, so where are we in the pandemic? This is the dashboard that I look at Monday through Friday at 5:01 p.m. when they post it to see how we're doing. If you go left to right here, kind of clockwise, you'll see we're tracking cases, testing and test positivity. Hospitalizations are in orange and deaths are in purple. And we're in our fourth wave here in Massachusetts. And what's really important to note is that we are headed in the right direction. Our cases have started to come down. Our percent positivity is coming down. Our hospitalizations that are a lagging indicator, they kind of lag behind improvements in cases and percent positivity. Those are steady. They're plateauing and starting to come down. And really importantly, deaths, you'll notice, didn't really come up too high this time. And in fact, in the last two waves, due to the impressive effect of vaccination, we've really been protected against burdening our hospitals with hospitalizations, and with the unfortunate deaths, though they do occur, are occurring at a much lower rate. than before, and primarily in unvaccinated individuals. So those are all looking good. And it really has to do with vaccination. So this is a complex graph, but I'll lead you through it. In each of these bars are the different age groups. Gray is unvaccinated, and blue is got at least one dose. And in the first age group, 0 to 11, makes sense. In Massachusetts, we have close to 900,000 kids ages 0 to 11. They're not eligible, they're not vaccinated, of course. But in each of the subsequent age groups, we are doing at or above the national benchmarks for percent of individuals who have received at least one vaccine. And importantly, in the older age groups, the groups that are more likely, if infected, to end up in the hospital or unfortunately die, we are doing amazing in terms of vaccination and exceeding the national benchmarks. So that's the good, excellent news about how we're doing in Massachusetts. And it's really a story of vaccination in addition to other mitigating effects. But the power of the vaccines cannot be underestimated. So what about the Delta variant? So first of all, Delta is everything that's out there. Delta is this orange bar, and what these graphs are showing week to week is what proportion of the COVID that's being identified is one of the different variants that's out there. And so this is June to the most recent last week, and it's all orange, and that means it's all Delta. Delta is clearly more transmissible, but it's not clear that it causes more severe disease. And the questions you ask anytime you hear in the news about the next Delta, the next variant, which may have a different Greek letter, is it more transmissible? Does it cause more severe disease? And do the vaccines still work against it? Those are the three main questions. The variants are going to happen. It's a fact of life. But those are the three main questions that we ask about each variant. And the good news is that with the Delta variant, that we have preserved efficacy against the vaccines. So all of the currently licensed vaccines in the United States protect against severe disease, hospitalization, and death for all the variants of concern. And I put it in big red across all these listed studies that have been published, that the efficacy against hospitalization, which is a very important marker, is greater than 89% for all of the studies that have been published. And many of these have been published during the Delta era. Now, there is lower effectiveness against a positive test and symptomatic disease. And so compared to the original COVID that came back in early 2020, and then the Alpha variant that came from the UK variant, the more recent variants had some decrease in efficacy against symptomatic disease. But again, hospitalization and death totally preserved. We also know that among immunocompromised people, the vaccines are less effective, and we'll get to that point. This is a complex slide, but I put it in because it illustrates a really important point, and it's a really reassuring point. And the point is that here we're going to look at how effective the vaccine is in real life during a period where Delta was the prominent variant. In this study, which had thousands of individuals in New York, you break down the age groups. So you've got your 18 to 49, 50 to 64, greater than 65, and then all age groups combined. And we're going to look at this top dotted line. And what the top dotted line is, what is the effectiveness of the vaccine at preventing a case or a case? So that case may be asymptomatic, it could be mildly symptomatic, but these are not individuals who end up in the hospital. And what you see is that across the age groups, yes, there is a decline from 91.7% to 79.8%, but it's not the same in all age groups. It's actually more of a decline in the 18 to 49-year-old group. 50 to 64 is declining, but not by that much. Greater than or equal to 65 is completely stable vaccine effectiveness. And so what's really important to think about with vaccine effectiveness is not just how good the vaccine as stimulating your immune system, it's how many times you are encountering someone with COVID. And if you have a lot more exposures, each one of those exposures is an opportunity for an infection. And the 18 to 49-year-olds are out and about much more than these other groups, interacting with people, having close contact. And therefore, it's an interplay between your behaviors and how well the vaccine works. So that's cases, asymptomatic, mild symptomatic, not requiring hospitalization. If you look at these same numbers for hospitalization, there is no decline during Delta. Every age group is protected against hospitalization during Delta. So I love this study because I think it really illustrates that there's a couple things going on. It's how good the vaccines are, but it's also about our behaviors. And obviously those behaviors are within our control. So those breakthrough cases, they will happen. And they're always going to happen until there's no community transmission. And in fact, if all of us end up being vaccinated, every single case amongst us is a breakthrough case. But we know that vaccinated persons are highly protected. They're much less likely than unvaccinated persons to get infected. The infections with the Delta variant in fully vaccinated persons are associated with less severe outcomes. And emerging data that if you have a vaccinated person and an unvaccinated person, and they're both infected with Delta, that a vaccinated person is less likely to transmit than an unvaccinated person. So that's all good news. Now look at Massachusetts data. So each week on Tuesday, they publish the number of breakthrough cases. And you look at cases, hospitalization among those cases, and deaths among those cases. So the proportion of fully vaccinated individuals in Massachusetts who have experienced a breakthrough case is less than 1%. Even lower among those cases, among those cases, how many of those individuals end up getting hospitalized? 0.03%. And then you can see the deaths among these individuals. So I find this so reassuring. And I think that this is a story that really isn't told as much and is not, when you look at the numbers, it's really hard to think of something you could reduce further than that. It's really impressive. What about kids? You may have kids and grandkids, and you wonder about those who are not able to be vaccinated now. This is a very important study that was published a couple weeks ago. And what they did is they looked at states with low vaccination among the people who are eligible, so among 12 and older, that's the population that's eligible. And then they looked at states that had a high vaccination. So the top group here is the reference, that's states with highest vaccination. So Massachusetts, for example, most of the New England states were in that bracket. If you compare the states with lower vaccination, emergency department visits and hospitalization among pediatric patients, so age less than 17, are threefold higher in the lowest quartile than in the highest quartile. And you can see this effect across these groups. So by having a highly vaccinated population that's eligibly vaccinated 12 and older, we are protecting our kids from emergency department visits and hospitalization. The other point is you hear tons out there about kids getting COVID. And there was some worry that somehow Delta was more severe. And that's why you would see kids in the hospital. It turns out in the same study that they showed that the percent of hospitalizations that result in an ICU admission, so getting really sick, is actually stable from pre-Delta. It's about 20%. The issue is because Delta is so much more transmissible and there's so many kids out there who are susceptible, that the volume is really what's driving this. Okay, so how do vaccines get approved and the recommendations made? So the first part is the sponsor or the manufacturer. They file an application for authorization to the FDA. The FDA has this internal committee. They have a very long acronym, very hard to pronounce, but they review all the data, and these are public meetings and usually on Zoom, so you can watch them. They review all the data and they make a recommendation to the FDA. The FDA leadership makes a decision, and then they will either authorize it and update a label, the label of the vaccine, to say this dose for these populations, and they do that part. The CDC then takes that information, and they have a committee called ACIP. ACIP is an external advisory committee. They're experts in vaccines, and they're the ones who, for years and years and years, are the ones who make the recommendations for the vaccine schedule. So shingles vaccine, all those vaccines, there are the recommendations from ACIP. They meet, they make a recommendation, and then they give that recommendation to the CDC director, and that is the decision that's made. In most cases, the CDC director accepts exactly what ACIP said. In some cases, they make modifications. So that's how the process works. Now, what's been confusing is that there have been statements made about boosters by this date before even FDA review happened or CDC review, but this is the process that has to be followed each time. So what are the current approvals? The only vaccine that has full FDA approval is the Pfizer 2-dose vaccine series, and in ages greater than or equal to 16. The other vaccine approvals are under this emergency use authorization, and we have the initial or the primary series, and that's the Moderna 2 doses, and that's only in ages 18 and above. The J&J single dose, again, ages 18 and above. And then the Pfizer 2-dose series, when you administer it to kids aged 12 to 15, is under emergency use. It's not had its full FDA approval. Additional doses are under emergency use, a third dose of either Pfizer or Moderna for moderate to severely immunocompromised, and that's 28 days after your second dose. And then the most recent is just for Pfizer recipients, a single booster dose at least 6 months after you got your primary series in eligible populations. So that's what's currently approved. Why would you need an additional dose? So in individuals whose immune system is down, the additional dose is really to get them to the level where everyone else is after 2 doses. So it's really thought of as most of the primary series, that some people just don't get enough after 2 doses. They need that extra dose. That's very different than a booster dose. A booster dose concept is you get your primary series. Over time, your immune system may forget a little bit about what it learned before, and you boost it to remind it and generate a long-lasting immune response. So they're different concepts. The group that is considered moderate to severely immunocompromised, they, several weeks ago, recommendation to get an additional dose as part of your primary series. And I have listed here what those immunocompromising conditions are. The booster dose is really only if there's 2 things happening. One is, does your immunity that you built on your first series wane over time and decrease over time to the point where a boost is necessary to preserve that vaccine effectiveness that we were talking about? The second reason you might need a booster is, what if there's a variant that is not actually covered by the vaccine? And then you would need a booster that would cover that variant. Unfortunately, that hasn't happened so far, so we've been really in a good state in terms of variants and coverage with the vaccines. So the questions about boosters are really, there are still lots of questions, and there are lots out there trying to figure out, what are we trying to achieve with boosters? Because some of the decline in vaccine effectiveness, as we just looked at with that study in New York, could be because behavior is changing. Less social distancing, less masking, and in a young population that likes to go out and socialize, more exposures. The other question is, what are we trying to achieve through vaccination? If we're trying to achieve reducing hospitalizations, severe disease death, we've gotten there already, at least right now with our current strategy. The data for boosters in terms of outcomes, clinical outcomes, is really lacking at this time, but we do know that the antibody response that your body generates is lower in people who have a breakthrough infection, and that you get higher antibodies if you boost someone. So that's kind of the rationale for why boosters might be useful, but also a caveat is that we don't really know about the clinical outcomes in terms of hospitalization and death. We do know about the safety. So the safety of boosters has been looked at in a couple ways. Interestingly, and I looked at the Pfizer FDA filing like 3 times to make sure that I was really reading the numbers. The Pfizer filing for booster approval is based on 300 clinical trial participants. And while there was no safety signal observed, it would have been too small a study to actually see if there was a safety signal. But in the real world, people have been out there getting boosters, even though it was not approved or recommended. So people were acting, and just going out and getting boosters. And so we have some data published 2 days ago related to the safety reports from those individuals. So between August 12th of this year and September 19th, there were 22,000 individuals who got boosters and who submitted safety, were tracking their symptoms afterwards to the CDC in this V-Safe program where you can go online and tell them how you're feeling. And what do we know about that? What we know is that the local reactions, like your arm hurting or swelling or redness, and the systemic reactions like fever, achy, those sort of things, are pretty much the same after dose 2 and after dose 3. So whatever you felt after dose 2, you're probably going to feel after dose 3, and that is reassuring. They found no unexpected patterns of adverse reactions. And they're obviously going to continue to monitor it. So we do have a pretty large study, basically a natural history experiment of people going and getting boosted, even though it was not approved. This is just a visual of this. Light to dark blue is dose 1, 2, and 3. And any injection site reaction, that's the soreness, you can see between dose 2 and 3 is pretty the same. Same with the systemic reaction, fevers, achiness, those sorts of things. Lower numbers of people reporting that they were unable to do their activities of daily living or unable to work or actually needed to get medical care. So this is very consistent with what we saw in dose 2. So are you eligible for a booster? And the second question is, should I get one? So people, we talked about who's the booster data. If you wanted to check if you were eligible, there's actually an online little service from the Mass Department of Public Health where you put in your info and it tells you. But the recommendations from the CDC are as follows. Who should get a booster? So the should is the strong recommendation. So people age 65 and older you should get a booster if you had Pfizer. So that's, again, all of this is qualified by if you're a Pfizer recipient. And if you are between 50 and 64 and you have underlying medical conditions. And the rationale here is that the risk of severe illness increases with age. And so this is the population where a booster, if it does prevent or reduce the risk of severe illness and having you end up in the hospital, that's a good thing. So that's the rationale for that group. It also applies to individuals 18 and older who are in long-term care settings like skilled nursing facilities. These are congregate settings, so there's a lot of close contact, and they often have underlying medical conditions. There's also two groups that they identified that may get a booster. And this is more of a discussion or thought process that you have internally about whether or not you want to get a booster. And it has to do with being in the 18 to 49 group with some underlying medical conditions. And then also if you're at increased risk of exposure due to where you live or the kind of job you have. So I'm going to go quickly through the FAQs, where to get a vaccine. So there are so many choices. And here I'm just highlighting choices outside of Mass General or the Mass General Brigham system. You will be getting communications through Patient Gateway and I'm sure through Senior Health about the options that are available here at the hospital. But there are so many different choices out there. It's very easy to find a vaccine. So you can do the searches online and actually Massachusetts, you put in your zip code, you put which vaccine you want, where you want to get it, and it's very easy. I tried this, I tested this one. You text your zip code to this number. It's really fancy. It gives you back the local places you can go, which vaccine they have, and you can also tell them if you can't leave your home, you can be eligible to get someone to come to your house and give you the vaccine there. So it couldn't be easier than that. Or if you just like the phone, you can call that phone number and they'll walk you through it. So lots of ways to get it. What if I got Moderna or J&J? And my recommendation is to sit tight. There is more data right now being reviewed by FDA, and then it will go to CDC, just like the process I showed you. The boosters for Moderna are expected to be a 50 microgram dose. The first two in Moderna were 100 microgram, and the booster application is for a 50 microgram dose. And as opposed to that, the Pfizer doses are 30 micrograms across the board. So it's a little bit of a different strategy there. Boosters for the Janssen or J&J are also expected. And as we know, these approvals are coming at different times for different vaccines. And we're also expecting some mix and match studies. So people who get Janssen then Moderna or Pfizer then Moderna. And those may change the current recommendations, which are really you stick with the vaccine that you got and you work with that series. So those recommendations may change, but I would sit tight. You saw the data about how great these vaccines are. There is no emergency or rush to get another vaccine at this time. What about getting other vaccines like the flu? All in the beginning of the COVID vaccine thing, it was, try to keep them at least 14 days apart. That was out of an abundance of caution. We learned a lot. They can be co-administered with all the other vaccines, so no worry there. And what's even better is when you're scheduling your COVID-19 vaccine, you may be offered to get your flu vaccine at the same time, and I would totally go for that. I just scheduled my mother-in-law via CVS, and I clicked yes. You can get them in each arm, and you're good to go. There's no concern there. When will vaccines be approved for kids age 11 and below? The FDA this summer wanted more data from the two companies that are doing this. They asked for larger trial sizes, and so those trials got fully enrolled. Both Pfizer and Moderna did that this summer, and Pfizer submitted their data to the FDA on the 28th. So I think Pfizer's probably a little further along in this process. And this push to get approved may have changed a little bit in light of the Delta variant because of the transmissibility that's been shown. Now, people often ask, can I do X, Y, and Z? Is it safe to do X, Y, and Z? And the way I think about it is it's a risk assessment. And a lot of us do this in our head, kind of without thinking that we're actually doing a risk assessment. But the first question you have to ask about any activity is, what are the risks of exposure to infected people in that activity? Outdoor, pretty rare that there's going to be a transmission event outdoors. It's just not a common thing. The size of the gathering. The more people you have, the more chances that one person there is infected and doesn't know it. Who is at the gathering? Do you know people at the gathering? And then they are all the kind of people who you know would not come if they felt sick, not come if they were exposed, are vaccinated, or you know their vaccine status. Get a sense of who's there, or if it's complete strangers, that's a little different. The proximity. How close are you packed in there? And then the other part of this is local community prevalence. It's very different to say go to a gathering here in Massachusetts where our community prevalence is coming down versus another community where there's a lot more virus in the community. And that goes hand in hand with the local vaccination rates. The second piece of this is if I get exposed, like I went to an event and I get exposed, if I know it or I don't know it, what's the likelihood I'll get infected? If you're vaccinated, you know that the risk is very low that you will get infected, but the risk is there. The next step is, if I get infected, what's my risk of severe disease? Again, vaccinated, very low. So you're going into lower and lower risk categories. If I get infected, the other question you might ask is, what is the risk I pose to others? And it's really about who's in your household because I've exposed them. And there the question is, are they at risk for severe disease? If they're fully vaccinated and not at risk of severe disease, then you kind of have to take that into account. So I think about activities, travel. If you're applying that framework, how am I traveling? With whom? To what place? What's the community prevalence? What's the vaccination rates? Gatherings with family, I think, are pretty safe if you've got a family that is well vaccinated, of those who can be, and is taking all the general precautions. Then you can go outside of your family and think about gatherings with other people. Dining out really matters about who you're dining with, because when you go to the restaurant and you sit at the table, you're face to face with the people in your party, not with other people. I guess at the extreme, you could think about nightclubs or mass indoor gatherings in locations that have high community prevalence and low vaccination. But it's a spectrum of potential risk, and you just have to think it through. And if you're vaccinated, you saw the numbers. You're at very low risk, even if exposed, to get infected, if infected, to have severe outcomes. Masking in Massachusetts, there is no public mask mandate. The exceptions are schools and healthcare facilities and the other places I've listed here. The mask advisory says that all unvaccinated people should be masked indoors. Vaccinated residents who are at increased risk from COVID or live with someone in their household who's at increased risk should wear a face mask when they're indoors. Cities and towns have done their own things. You just got to follow the rules where you are in your city and town, and businesses have done their own thing. So you follow the rules of that business. And I'll just end by saying that I try to keep this all in perspective. The vaccines are amazing. I just can't imagine thinking where we were this time last year, heading into the winter, no vaccines yet. We are in such a different place, and we're also in a different place because we're in Massachusetts in the Northeast, where we've just done so well with vaccination. The focus really needs to be on vaccinating the unvaccinated, because those are the people who are more likely to spread. They're more likely to end up in the hospital and have bad outcomes. And then we just layer strategies as we need to. The key metrics to follow are that community prevalence in Massachusetts and how much vaccination we can do and how effective those vaccines remain. And I'll stop there.
Thank you. Dr. Levine.
Well, Erica, that was really fantastic, and it was a lot of information. And just for those on the Brady Bunch view watching us, we have to keep up with all of this too. And it's really challenging and hard to do. And to have it all put forth like this is really great. And I'm glad that we have this recorded so that you can all listen to this again, knowing with the caveat that things are always changing. And as we get more information and more people are vaccinated, and or less vaccinated in some states, it's really important to put this all in context. And I will just give you an anecdote. My daughter, having canceled her wedding twice previously because of COVID, just had it 3 weeks ago. Everybody that was there was vaccinated. Many people got tested before they came. All of the events were outdoors except for one where everything was placed far apart and where there was tremendous ventilation. And we are now just about 3 weeks out and not a single solitary person has gotten sick. So I think it's really, really, and we were very, very careful about it. And people who wanted to wear masks could wear masks. And so it's important to know that people flew there from some places, but most people did not, but everybody was vaccinated. So life does have to go on, and life is going on, and we are lucky to live in Massachusetts and to have people that are so well informed that they can tell us about what to do and help interpret all of the what seem to be confusing guidelines, especially in. It's really great in a place like Massachusetts, where you guys have done a great job of getting vaccinated, your first and second shots, and many people have gotten boosters already, as Dr. Chenoy mentioned, before it was even recommended. But those of us who've had Moderna or J&J will have to wait. But this is all really good news. And with flu season coming, really can't say, stress more strongly about getting your vaccine. So I'm going to switch gears here for a second, and I will speak quickly so that all the questions that are here that have been come up on the chat or were submitted earlier can be answered by Dr. Chenoy. I'm Sharon Levine. Again, I'm the section head for geriatrics at Mass General in the Division of Palliative Care and Geriatric Medicine. And I just wanted to give you some updates today. And we're so glad you're all here. We love seeing you. It's just been great. We've been going 1.5 years now, and you've become old friends. I recognize you when you come to clinic. I recognize you on the Brady Bunch. So I wanted to confirm that with our move from 165 Cambridge Street, not all of you were patients of senior health and now geriatric medicine, but because we know that there are folks that are on here from other places, but we have moved from 165 Cambridge Street to Yawkey 2, which many of you know because it's where you get a lot of your outpatient care anyway, and it's close. We love it because it is close to the hospital, and when anyone is admitted, we can go over and make a quick visit, which was harder to do from 3 blocks away. And we're close to the emergency room too, so we can hop down there. So Yawkey 2 is part of the main complex, the one that's called 55 Fruit Street, but Yawkey 2 is the building that we're in on the 2nd floor, up above the cafeteria, at the end of the escalator, and it's very convenient to get to. We share our space with the hand clinic and with the urgent care clinic, which is very convenient for us. And there is we can still draw bloods there, and we can even get some x-rays in that clinic too, because the hand clinic is there. We have our flu vaccines. So those of you who come to clinic for regular appointments can get your vaccines when you get there. Or you can go and get your vaccines wherever you get them, CVS, Walgreens, whatever you do. But jot down the date. We'll enter it into your chart. If you have your vaccine administered here, it will go into your medical record here. Otherwise, we'll add it. I wanted to make a short announcement or give you an explanation about lab results. When you come to clinic and you get lab results, some of those are done in a day and some of them are done over 2 weeks. So the clinicians, whether they're nurse practitioners or docs, some of those things dribble in, over time. Some of them will come there that day and some of them won't come for 2 weeks. And so we even though you see them as they come up on the patient gateway, we usually wait till we have everything so we can send you a letter or give you a call. Most of us will contact you if there's anything to be concerned about. You should know when it says hi on something, it could be like one little ditzel above normal, and it doesn't mean anything at all. And other things are, but for you, when you see red or high, it's alarming. But we would always call you if there's anything to worry about. So, but we won't give you those immediately because we want to wait till all the labs come in. I'm going to talk for a minute about virtual visits. We're still doing virtual visits for people who feel more comfortable, people who have to drive further. We all tend to cluster those so we can try and stay on time because it's hard to mix in-person visits with virtual visits. So for instance, I have an afternoon where I do a lot of virtual visits, and a lot of the other doctors do also, and nurse practitioners. We're happy to do them. We really would like you to come in at least once a year or once every 6 months in person if you can, because it's really nice to examine you. And if you have an urgent visit that's hard to see, I mean, I can say, stand up, sit down, do Simon Says, put your hands here, put your hands here, put your hands here, stand up. I can do a lot of that stuff, but I can't feel your belly. I can't listen to your heart. And I can see a picture if your leg is swollen, but I can't examine the rest of you. So it's important to have some of these be in person if you can, but we're very happy to see you virtually with one caveat, which is that now that the public health emergency is over, we are not able to see people out of state because we do not have malpractice privileges in any state outside of Massachusetts. We are working on getting licensing outside of Massachusetts in some close contiguous states to Massachusetts, like Rhode Island, New Hampshire, and Maine. But I know a lot of you are snowbirds. A lot of you spend half the year in Florida on the east or west coast or other places. And what I would urge you to do, because it's really hard, we can't examine you long distance for things that are complicated. You can always call and give us a call and say you're worried about something. But I think if you're somebody who spends many months of the year away, it's good to line up a primary care provider where you are so that you can actually have an appointment. None of us minds getting, just like in the old days when you used to call us and we would just say what we recommend, but we can't do a regular appointment where we see you. So more to follow about that. We're hoping that some of us will be licensed in these close states, and that we can do you virtually, see you virtually. I think that this is true for many other clinics at Mass General Hospital now as well. I want to just encourage one more thing before we go to the questions. I want to tell you all that many of us take a lot of time to ask you a question, which is, what matters most? What matters most to you? Because alongside you getting around, your mobility and your mentation in your mind and the medications that you take, it's really important to us what matters most, because that frames everything we do. Some people will say it's their independence. Some people will say it's not being a burden. Some people will say it's their family. And it's important for two reasons. One, to help us guide you with your care and tell us the kinds of things you want and you don't want and what your philosophy is about your care, because this is about you. It's not about us. It's about you. And the other is for you to have healthcare proxies or agents who can act on your behalf in the case that you are not able to act on your own behalf, either because of a serious illness or because your memory is so impaired that you can't make certain decisions, or because things happen in real time and you just got to be able to have conversations and you may not be able to do that, is to assign a healthcare proxy who can speak for you if you cannot speak for yourself. But it's important for that person to know what is most important to you because they're acting on your behalf. They're not acting about what they want. It's what you want. And so It's important to have these conversations with your doc. I love having them. I could talk about this all day long. Life, death, disability, anything. What's important to you? And because it's not about me, it's about you. So it's important for you to talk to your family. And to that point, we're going to put up in the chat, if it's not already there, there's something I really love, which is called prepareforyourcare.org, www.prepareforyourcare.org. And it has vignettes. How do you talk to your doctor? How do you talk to your family? I'm going to assign my niece as my healthcare proxy. And then I'm going to tell my daughter why I chose my niece. Things like that. It's very multicultural. It's very, the literacy level is very accessible to anybody. And there's things that you can work through in addition to these vignettes where you can think about what you want and express it. I love it. I sent my patients to use it and they really like it also. So I'll put that in there. You can get on there for free. You don't have to pay for it. There's a guest option where you can go in. And I think that is a really wonderful tool. And you should ask your doctor. If your doctor doesn't ask you, you can make a separate appointment just to talk about your goals for your care and for in case you're somebody else's healthcare proxy. I feel it's a blessing to have a healthcare proxy and a blessing to that proxy to know what you want, because that's the only way that they can act on your behalf in an informed way. So I wanted to talk about that and to really encourage you, whether you're in this practice or any practice, to talk to your healthcare providers about that. I think it's one of the most important things you can do. It's like an insurance policy. You never know whether you're going to get hit on a brick that falls from a 20-foot building and get knocked out, or be in a car accident, or get COVID, or have something that have a massive stroke for that instance, for that matter, that might make you not be able to talk. But having had those conversations with the people you care about and your docs, we can have a guide if you're not able to talk to us. So life deals you lightning bolts, and it's always good to be prepared. I've never had a patient who didn't want to talk about it once we took it out of the box. You can always put it back in the box and not talk about it anymore. But it's good to take it out of the box, ask some questions, and put it back in the box, even if it's not something that you feel comfortable talking about. So I'm going to stop there. We're doing lots of stuff. You've talked to Matt Russell, the medical director. He's out of town this week, but all the projects we're doing, we have a new pre-operative optimization surgical health clinic that we're partnering. We are working with some of the HIV folks around aging positively. We're going to start doing that. We continue to have our GIFTS program, which is our inpatient fracture trauma service. We're doing consults in geriatric medicine clinic, the Mass General Geriatric Medicine Clinic on Yawkey 2, and we're seeing some of our primary care patients. And so we hope to see those of you who are here, whether it's virtual or in person. And I'm going to make sure that all the questions that I'm sure came for Erica get a chance to get answered in this last 15 minutes, or any questions you have for me later.
Great. Thank you, Dr. Levine. That was wonderful. And I just also want to put in a plug to encourage you to take a look at Prepare for Your Care. We've actually done special Prepare for Your Care online or virtual events. And I know some of you at the town hall today have participated. One thing I really love about this program is that there are many videos that many of our patients and their families have found very helpful. They're sort of like role plays that demonstrate how you may have some conversations with your family and friends about some of these topics that many people find very helpful. And there also are lots of resource materials. So with that, I'm going to go. I think this is really the first question, and this is for Dr. Chenoy. And the question is about, the statement is, hepatitis A has a blood test to confirm there is immunity. Is there anything like that for the Pfizer vaccine or for any other vaccines, or any reason to ask for that kind of test?
Well, I love that question. I get it all the time, because I think people know that with other sorts of illnesses, we do have what we call correlates of immunity, a test that can be interpreted to say, below this threshold, you're not protected, above this threshold, you are. We are not there with COVID yet. There are antibody tests that can assess for prior infection or response to the particular spike antibody, but they're really not interpretable in a way that we can make decisions about it. And what I mean is, if it's some number, it doesn't tell me that, for example, you're immunocompromised and you don't need your third dose, or you're over 65 and you don't need a booster, or that you've gotten your first dose and you're protected and don't need the second dose. None of those decisions, actions that you would take based on that test, there actually aren't any actions. And so it's being studied. So there's obviously a lot of interest in having such a marker, because you could identify people who need to be actually vaccinated again and those who don't. But we're not there yet. And at Mass General, there are many kind of studies ongoing, or at least a few studies that I'm aware of, that are trying to establish a correlate between the specific antibody tests and your protection against infection. So not there yet. I would stay tuned. I think eventually we will have that. I would be just wary that there are a ton of tests out there, and it's kind of the Wild West in some ways. So I would, if you got a test, people can be falsely reassured and falsely worried about it. So my thought on those kinds of tests is they're not worth getting.
Thank you. Another question. Do we have data yet on how long the booster shots last?
Well, the question is, what do we mean by last? That will only be known over time in terms of they're checking antibody response, of course, but the big question is, does it prevent either infection, hospitalization, or death? And with all of these studies, we're kind of in a living experiment, because we can only know these things as time accrues. So if people have been getting boosters over time, as you know, like people were out there getting boosters, we will have some information over time as to their risk of infection, hospitalization, and death. But again, that is colored in part by the sorts of behaviors that are going on, the amount of virus in that local community. So it's going to be really hard to tease apart the clinical outcomes related to boosters. In the studies that they're doing, like the 300 patients that Pfizer submitted to FDA, they're measuring antibody levels, but we just talked about how we don't have a cutoff for those antibody levels or a way to kind of meaningfully interpret them at this moment in time. So I think we'll have to just stay tuned and see what we get out of boosters.
So another question, and I know you talked about this, but we've heard a lot of information today. Can you just remind us again about the J&J?
So J&J has released non-peer-reviewed data about second doses for individuals who got a single J&J. They have been studying it. That data is being submitted to FDA, and so all we know is that they're going to be reviewing it, and we should probably hear soon. I mean, what I've heard from colleagues is by the end of October, there might be an announcement about a second dose of J&J, but that's, what you hear through the grapevine about these things. Their study of the second dose has not been published in a peer-reviewed journal yet, but I expect that will come out as well.
Dr. Chenoy, can you explain to everyone what you mean by a peer-reviewed journal and why that's so important?
Yes. So one of the massive challenges of this pandemic has been the just fire hose of studies that are coming out at us all the time. And peer review is the process by which, say, I do a study, I write it up, I submit it to a journal. That journal sends it out to experts in that field. They review it. Statisticians will review it. It undergoes formal peer review. Usually you don't get it accepted right away. They've got questions. You as the authors need to answer those questions, do additional experiments, sometimes rewrite the manuscript and send it back in until they agree that it can be published, and then it gets published. What's been happening during the pandemic is that, there was a lot of urgency to get information out there. So many people put out what are called preprints. They have not been peer reviewed, but they're putting that data out there online so people can at least see what they're working through. Often we've seen that papers that were set up as preprints that had lots of maybe, how to put this, newsworthy findings, by the time they get to peer review, are not really what they were before. So I would just say caveat emptor, or beware of things until they get to peer review. Now, peer review is not perfect, but it does provide another layer of external review that can often lead to different conclusions from the papers. So we kind of have a lot of stock in peer-reviewed papers, and especially peer-reviewed papers in very high-quality journals, because you know that they put the authors through the ringer. And I know that because I've been through the ringer many times. One of them took me 9 months to go back and forth to get a paper published. So.
All right, thank you. Can people who had the J&J vaccine get a Pfizer booster shot?
Not by the current recommendation. So I think it's can and should. So you shouldn't, because it hasn't actually been studied. And I know I can put myself in that position. I mean, I'm a Moderna person, so I'm going to sit around waiting until it's actually indicated for me, which it isn't even right now. I can understand the kind of urgency to get something, especially with the J&J, which wasn't as robust as the mRNA vaccines in terms of symptomatic illness, although hospitalization and death, excellent outcomes. That said, if the study comes out and says really the second J&J is the way to go, you've already kind of shut the opportunity to have the kind of gold standard vaccination. It could be in a few weeks that they release the mix and match studies and they say, yeah, you can actually mix these all up. But we don't know that yet. And so given what we know about how protective the current initial series is for most people, I would sit tight. If you wanted to get it, people obviously have. You saw that study of 22,000, and there were a lot of mix and matches in there. And the safety profiles seem about the same. But I think what you really want to know is the efficacy. And are you really getting the most bang for your shot by doing the mix and match? We just don't know.
Another question I think that everyone is thinking about is, do you think that we're looking at booster shots for the COVID vaccines, just like we get an annual flu shot in our future?
That is a great question. I don't know. I really don't know, because the it really depends on a couple things: the durability of, or how quickly our immunity wanes to the point where it's actually causing a problem, and we end up having hospitalizations and deaths and that sort of thing come up. It depends on the virus that's circulating and if there are variants that are covered by this vaccine or other. I mean, the concept of the flu is that each year there are these changes with the flu that require us to get a new vaccine with a different mix in it. I don't know if COVID will be like that, or if it may be just for a couple of years while things are settling themselves out and we're getting enough immunity and cross immunity against the different other coronavirus variants that come out. So only time will tell. And maybe if we touch base in a year from now, we'll have the answer to that question.
Great. I think maybe the last question is the Pfizer third shot and booster the same dosage? Is it the same dosage for all three?
Yes. So for Pfizer, they went 30, 30, 30. That's the dosing. For Moderna, it's 100, 100. And what we expect will be submitted and approved is a half dose for the booster of the Moderna.
Okay. I think that we have covered all the questions. Anything else from anyone in the audience?
I'd like to make one comment, which is that what Dr. Chenoy is saying is we are living in a time of uncertainty. It's sort of unbelievable what we have accomplished in less than 2 years If we'd been able to do this with HIV or Ebola or other things or Lyme disease, I mean, it would be, we'd be amazed if it happened, and it still hasn't happened. So what has happened, even though this is the most alarming pandemic that's ever come, we've gone from identifying it and sorry, one second here. Identifying this problem, coming up with a vaccine, vaccinating people, the possibility that we can decrease death and hospitalization and disability with all of this uncertainty, including the variants that keep coming up and trying to foil us and live inside the, mutate inside the people who are not vaccinated, is incredible and remarkable. So even in this situation where there is such uncertainty, we have made such incredible progress. And I don't want to underestimate all the stuff and it's going on as we speak, which is why we're all confused all the time. But we're also making tremendous progress. And I don't think that should be lost in any of this. And it's why I think that the talk that Dr. Chenoy gave to you today is such a wonderful, wonderful update of what has happened and is still happening and is yet to happen.
I see one last question, which I can answer about when you're going to hear from Patient Gateway. I've been reviewing what the content is that's coming out. There's a few of us, and I think it's supposed to start cascading on Friday, but because it goes out to like 1 million people, it happens over a course of a few days. So just keep an eye out for it. It is coming soon. In the interim, you all know right now if you're eligible, so you can go out and use Vaccine Finder or text or call if you wanted to get yours scheduled between now and then. But I would anticipate over the course of Friday through early next week, you'll have all the info you need about clinics at MGH and other Mass General Brigham locations.
Yeah, and you have one last question, Dr. Chenoy.
Okay, I've been exposed because I was, but do not have symptoms. Okay, so this is a little bit of a tricky one because while you are exposed, you're fully vaccinated, you're not subject to quarantine. I would say because booster is like a walk to a booster instead of a run to a booster, that I would just wait it out a little bit, because if you get a fever or achy after the booster, you're going to wonder, is it related to the exposure or is it just the vaccine? And better to just like not have that question pop in your mind. Again, it's not urgent to get the booster. So I would just wait it out, even though technically you're not in quarantine because you're fully vaccinated.
So I want to thank Dr. Chenoy. I think you all now have a better appreciation for why we've been so lucky to have her leading our response to the COVID pandemic. So thank you, thank you. I also want to put in a plug for the October town hall, where we're going to have one of our primary care doctors who's an expert in genetics and actually has her own preventive genetics genomics clinic in primary care. And one of the reasons why I think this town hall will be very interesting is that she's going to be talking about why it is so important for all of us to document our medical histories for the benefit of our children, our grandchildren, and others. So that will be coming up. And also please know that when this recording is posted, and we're going to try to get it out to you as quickly as possible, please feel free to share it and promote it with your friends and family. I think this information is invaluable, and we are getting overwhelmed with questions that are very difficult to respond to individually. So please share this with anyone that you think might benefit from this information. Thank you to Dr. Levine, to Dr. Chenoy, and to all of you for joining us today. I hope you have a wonderful rest of your day.